Hi, this is Dr. Jackson Perry. I have heard, and some people are wondering what's next when they heard about WHO talking about hydroxychloroquine being removed. I think the WHO is going into what's called a murderous rage. They have no good intentions. I'd hate to say this, but at this point, I'm just sick and tired of the WHO, of CDC, and any other incompetent facility that's trying to mislead people. Let's start with the basics. I'm going to share two things here. First is that the patient population in which hydroxychloroquine is being ordered or recommended to be used is the wrong population. What do I mean by that? There's something called the natural history of a disease. When a person comes into contact with a communicable disease, stage 1, you can't find anything. Stage 2 is when they have the disease already in their body, but it's too early to tell. They may not have any symptom. It'll have to be an extra, super, ultra sensitive test that can even find any semblance of the disease in their body. That's stage 2. Stage 3 is when they have the disease. You can tell either by clinical signs, by laboratory findings, the usual things that you can do to find that disease. And then stage 4, when the disease has run its course, which may then lead to what? Complete recovery, partial recovery with disability or without disability, death, and in most cases, with COVID-19, we know that when there's no treatment, this is what's going to happen. And so the question is, cytokines are responsible for the death of patients in COVID-19, a cytokine storm. So you give hydroxychloroquine because it has at least 6 to 7 different mechanisms that I'm sharing with my upcoming book that are responsible for its actions. Hydroxychloroquine is not just something some witch or some politician in the White House just cooked up. Like I said, there's a reason for its effectiveness, and because it's focused directly on certain mechanisms by which the SARS-CoV-2 virus kills. Cytokine release, cytokine syndrome, cytokine storms. It prevents that. And in addition, we found that it clears the virus. So let's go a little further here. Dr. Mera, who is not an internist, is not an emergency physician. He is a surgeon, for goodness sake. He has no clue about the pathophysiologic mechanisms that are involved in the process. And I think he just brought his head into COVID-19 to gain himself some fame. And it's based on his paper being published in the Lancet that the WHO head, that guy, whoever he is, decided that they're going to pull hydroxychloroquine. Now, let's go back to the basics. You see, there are two kinds of things that can happen when you're treating a disease. 2. 1, you may be treating it on time, early enough, or with COVID-19, a little bit too late. What's called the EUA is an emergency use authorization. And that EUA says give it only to hospitalized patients, 50 kilograms or more. But by doing that, you're giving the drug too late. But if you go to the clinics, in the clinics, the patients are getting it before they need to be hospitalized. So you're going to find that in the cohort of patients in the hospital, the failure rate will be higher for hydroxychloroquine. And as I mentioned in my book, you have actually failed the patient if the patient requires hospitalization before you give them the drug, which in effect nullifies the purpose of giving the drug in the first place, because cytokine levels have been built up to levels that are toxic enough to alter the body's systems and bring them to a level of overwhelming infection that can present in the ER with septic shock, acute respiratory distress syndrome, and so many other issues such as kidney failure. You don't let patients get to that point. Now, the other thing I want to tell you is that if you let patients get to that point, now you have a cohort of hospitalized patients of which about maybe 2/3 will survive. And out of that 1/3 that will not survive, just picture this. Could be you and could be a healthcare professional. But not only that, the next thing is, of all those patients that go to the intensive care unit, about 2/3 of them will not come out. Now, as we said, COVID-19 is a cytokine storm disorder in the way it affects the body. I'm going to read something to you, a little bit from the book. Infection with severe COVID-19 is a highly toxic and inflammatory state where the body literally is cooked in its own inflammatory soup kitchen of cytokines. The high cytokine levels are pro-arrhythmic, and in addition, COVID-19 patients also experience additional cardiac events such as acute ischemia and heart failure. I'm going to give you the numbers later in the book. But you see, if you're at risk of developing atrial fibrillation when your cytokine levels rise, and you are at risk of developing any kind of arrhythmia when you go into septic shock, which is quite common in one series in Wuhan, China, that I'm going to be sharing in the book, here's the truth. From all the evidence that we have gathered so far, from clinical trials, from prospective studies, retrospective studies, the COVID-19 infected patient that is hospitalized is a soup kitchen of cytokines. Cytokines are responsible for prolonged AFib and development and maintenance of AFib and other arrhythmias. So a COVID-19 patient who is sick is basically what? A pro-arrhythmic patient with or without hydroxychloroquine. And the other question I'm going to then ask you is this. How many of the outpatients develop arrhythmias that are life-threatening? I worked in the telemetry unit. I ran an ICU for 5 years. I know exactly what happens when patients are on the unit being monitored. Some of them will have brief runs of VTAC, not VFib, VTAC. Less than 1 second sometimes. Flips sometimes. And then we check electrolytes and we find out, oh, magnesium is low. Let's correct it. And do you know that when a patient is sick in the intensive care unit, that they are more likely to have electrolyte abnormalities? We all know that. So Dr. Mera and his people who are being reimbursed or being given monies by all these drug companies, you are a surgeon. You don't care for these patients the way we do. And you don't even care about their soul, their spirit, and their bodies like I do. I know some of your friends, and I just spoke to them. And that's why I'm upset that you will actually place your name on a paper that endangers people's lives. Doctors in our patients, many of them are prescribing hydroxychloroquine to their patients, and those patients never need to be admitted. And guess what? Your cohorts are coming from hospitalized patients with COVID-19. You got the wrong set of people that you're studying. And if you do well-grounded clinical trials, randomized, placebo-controlled, double-blinded, you will not be doing this. Because I'm upset. I'm upset because the WHO has the audacity to say they're removing something that they know works from so many different countries around the world. Even in Italy, 60, 70, 80-year-olds who are taking hydroxychloroquine for lupus and rheumatoid arthritis, they found out that 90% of them don't even have the virus in their bodies. And those who have the infection are not getting so sick that they need to be admitted. So let's take a break from this. I'm standing up to the WHO. I'm standing up to the CDC. I'm sick and tired as a doctor listening to all this crap from paid clowns who want to pretend that they're actually doctors. Doctors care. And when I look at that paper, I'm upset because the guy is saying, you know what? Despite, if you understand how clinical trials are done, you will not start your statement in the abstract by despite. Despite means you have expectancy biases and a whole lot of other biases. This is Dr. Caxton Perry. Don't mind me. This is not my usual self. I'm usually fun to live with and laugh with. But tonight I'm just upset because they want people to die. And some people are going to follow those recommendations by the WHO and stop prescribing a drug, the only known drug that works. Remdesivir is going to fail. There are going to be better drugs that come up. But in the third world and developing countries that don't have that kind of financial resources, when we choose between hydroxychloroquine and some of these brand new drugs that are going to cost thousands of dollars, you decide. I come from a third world country, all right? And I want something that works for them, that they don't have to become slaves to the IMF, International Monetary Fund, or develop any trade deficits that can cripple the economy in no time. So this is the truth, and you're going to get those truths in my upcoming book, COVID-19 Physician Treatment Strategy. It's going to be out pretty soon. Have a wonderful day. Dr. Caxton Perry.